Good morning, everybody. All right. Welcome to Innovations in CF Pharmacotherapy. Today we have really great speakers, and the objectives for today's session are to evaluate the reports of mental health adverse effects associated with highly effective modulator therapy, discuss dose modifications of chronic disease state therapies based on drug interactions, as well as pharmacogenomic variations. And finally, we will review pharmacist and pharmacy technician-led initiatives impacting successful patient health outcomes. My name is Katie Hobart. I'm one of the moderators for today's session, and I am a pharmacist in Tucson, Arizona for the pediatric and adult CF centers. So as I said, we'll have 5 sessions today, and they will be covered by the following presenters. And I'd like to turn it over to Laura to introduce our first speaker.
Good morning, everyone. Thank you for coming. My name is Laura. I'm the pharmacy technician from the Pediatric and Adult Centers in Billings, Montana. Our first speaker is Alize Paracha. Alize is currently a clinical assistant professor at the University of Oklahoma School of Community Medicine in the Department of Pediatrics in Tulsa, Oklahoma. She has received a Bachelor of Science in Biochemistry, Master's degree in Prevention of Science, and Doctorate of Medicine, all from the University of Oklahoma. She completed her residency training in general pediatrics at the School of Community Medicine in Tulsa, Oklahoma in June 2023. During her residency training, she became more involved in pediatric pulmonology research, which led to collaboration with the Cystic Fibrosis Center in Tulsa, Oklahoma. Specifically, she is investigating CFTR modulator therapy and its effects in individuals with cystic fibrosis. This includes effects on mental health and pancreatic function.
Hi, thank you for that. So I will be going over our project that evaluated mental health adverse events related to elexacaftor, tezacaftor, ivacaftor therapy, which for time's sake, I will refer to as ETI therapy in individuals with cystic fibrosis. I have no relationships to disclose related to this presentation. So a little bit of background. Since its approval in 2019, ETI post-marketing studies have suggested potential mental health adverse effects. Specifically, there was mention of symptoms of depression, anxiety, sleep-related changes, cognitive changes, commonly termed as, quote, mental fog. And these are similar to post-marketing reports released with earlier CFTR modulators. In addition, case reports were published that revealed some individuals were experiencing an increase in baseline depression, insomnia, and cognitive changes. These effects were ameliorated by dose change or dose reduction, but for some individuals, ETI therapy had to be discontinued. As most of us may know, children and adults with cystic fibrosis can exhibit changes in their mood due to their underlying chronic systemic disease. There's some literature to suggest that there's a high prevalence of comorbid anxiety and depressive symptoms in patients with CF, ranging from 8% to 29% in children and adolescent patients with CF, and 13 to 33% among adult patients with CF. Therefore, it is essential that we further evaluate any mental health adverse events that are being reported for ETI therapy specifically. So how did we go about studying this? So we did a retrospective review of adverse event reports in the FDA Adverse Events Reporting System, which I will from here refer to as FDA AERS. We looked at reports where the suspected medication for the adverse event included ETI, and we looked at reports that were submitted to the FDA within January 16th of 2019 through December 30th of 2022. A little bit of background about the FDA AERS for those individuals like myself who are mostly taking care of kids from the clinical side and may not encounter them as often, it is a database that contains information on adverse event and medication error reports that are submitted to the FDA. This is designed to support the FDA's post-marketing safety surveillance program for drug and therapeutic biologic products. The cool thing that happened is that the FDA launched a FDA AERS public dashboard. This was primarily done for COVID-19 emergency use authorization products. This is a highly interactive web-based tool that allows for really anyone to query the data in a user-friendly fashion. The intention of this tool is to expand access of the wealth of data that the FDA holds to the general public. So anyone can search for information related to human adverse events reported to the FDA. And a lot of these reports are submitted by the pharmaceutical industry, healthcare providers, and consumers, and thus are available for data analysis. So this is an example of what the homepage looks like for that public dashboard. If you click this search icon right here, you can search for ETI. And this is what will come up. And this is data as of June of this year. And then if you click this listing of cases, this basically generates an Excel spreadsheets of all the reports that were submitted for that particular medication. We did apply some exclusion criteria. So we excluded any reports that included other suspected ingredients, any mention of fetal loss, or any mention of child abuse. We excluded reports that did not include at least one of the 6 mental health categories of interest, which I will go into detail in a later slide. And we did exclude reports that did not provide a patient's age, and I'll explain why in the next slide. We then used descriptive statistics to summarize the remaining reports. So this is a visual representation of how our exclusion process went. So initially, there were about 8,000 reports for ETI. Once we applied our exclusion criteria, about 600 reports remained. And because there were some reports that did not have a patient age reported, that did cut down those number of reports by almost half. So the remaining final cohort of reports were 268. And then, as we know, mental health symptoms and the predominance of a particular mental health symptom varies by age, and then how they're identified and reported also varies by age. So we felt it was important to then categorize these reports by age groups. So as you can see, the most number of reports were within the 18 years old and older population, followed by the 12 to 17 years old age group, which captures our adolescent population. And then we also had some reports with those younger kiddos with CF in the 6 to 11 years age category. This kind of shows how we categorize the adverse mental health events that were reported in these FDA reports. And we categorize them in 6 different categories: aggression, anxiety, depression, sleep-related changes, suicidal behavior, and completed suicide. Under each box, we have given examples of some terms that were used by authors of these reports that helped us then categorize them in these general categories. So let's talk about the results. So this is a graph looking at the number of cases for the mental health symptom or disorder within each age group. In the x-axis, you will see that we have separated them by the age groups, with that last group being the missing age. In general, there were reports among all age groups, including that younger population. Anxiety and sleep disturbances were by far the most commonly reported mental health adverse event in all age groups, but it's also notable that depression-related symptoms were notable in the adolescent population and in the 18 years or older population. As I mentioned, we did have to exclude some reports because they didn't report a patient age, and I did want to kind of highlight that the number of reports that could have been included in our analysis was this missing. But within that group as well, you can see anxiety, depression, and sleep-related changes predominate. This kind of highlights general demographic information. So by sex, it's split pretty evenly, though there is a female predominance as far as that final cohort of reports we analyzed. And as I mentioned before, most of the reports were of individuals who are 18 years or older, followed by the 12 to 17 years old age group, which is our adolescent population, with the smallest number of cases being in the 6 to 11 years old age group. I do want to mention that there were 3 reports that did not include the patient's sex. Of these reports, 1 was within the 12 to 17 years category, and 2 were within the 18 years or older category. I wanted to highlight other very interesting information that's included in these reports that are submitted to the FDA. The report on the figure on the left shows the reporter type that submitted the report to the FDA. And as you can see, most of them are healthcare professionals. The 20% of the reports were submitted by consumers. The one on the right is interesting in that the authors are prompted to assign a seriousness level as far as any outcomes that the individual may have experienced from this adverse event. And thankfully, most authors deemed that the individual only experienced non-serious outcomes from that mental health adverse event. But about a third, a little over a third, did feel like the individual experienced a serious outcome from that adverse mental health event. To dive a little deeper as far as non-serious versus serious, so as I mentioned, most of the reports were deemed as non-serious, but if you as an author deem it as a serious outcome, you are then prompted to categorize that serious outcome into one of these 6 different categories. And these categories can be as severe as death or disability, but it also includes life-threatening outcomes, an outcome that resulted in a patient hospitalization or required a surgical medical intervention. There is an interesting option called other outcome, and essentially what that means is if an outcome did not clearly fall within the other categories, but it could have jeopardized the patient or could have resulted in a medical or surgical intervention, it typically fell in there. And so as you can see, as far as the most common serious outcome that was reported, it was this other outcome category and hospitalization. To just detail further about these outcome attributions, this graph kind of looks at reporter type as far as what was deemed as a serious or non-serious outcome. So it is similar to what we've seen in the previous slides. Most of the reporters thought that the outcomes were non-serious, with healthcare professionals predominating as far as the reporter type, and then the other outcomes and hospitalizations being the more serious outcomes that were reported. And in both those categories, healthcare professionals were the authors of those reports. So to summarize, as you guys saw, we started off with about 8,000 reports that were within this FDA AERS database. And after we applied our exclusion criteria, we saw that only a small portion of the adverse event reports for ETI were related to mental health. Mental health adverse events did exist for all age groups, even in the younger kiddos, with anxiety and sleep disturbances being the most commonly reported. But as we saw, depression-related symptoms also being a commonly reported symptom within the adolescent and the adult population. Authors of most reports were healthcare professionals, and about 1/3 of the reports were assigned as having serious outcomes. And of those serious outcomes, we saw it was that category of other outcome that could have resulted in a medical or surgical intervention and hospitalization. There are some important things to consider with the database that we used, which has a wealth of data. I think there's a lot of potential for future data analyses, but it is important to note that existence of these reports does not establish causation. And age was excluded from many of these reports, which limited our analysis. And then it's important to note that the impact of certain stressors or other coinciding variables, such as the recent COVID-19 pandemic or the severity and progression of an individual's underlying CF disease, simply could not be measured in our project, though they can have an impact on an individual's mental health. And then there is certain information that the author can document in these adverse event report forms that unfortunately are not readily available in the FDA dashboard. And examples of that is an author can actually report if the adverse effect stopped once the medication was stopped. Unfortunately, that information is not in the dashboard. And then in addition, if you wanted to do further analysis from a health equity standpoint, authors can report individuals' race and preferred gender, but that information is not readily available on the FDA dashboard. So in conclusion, ongoing monitoring while on ETI therapy at any age is needed to determine the true significance of these mental health adverse effects. Further studies are warranted regarding CFTR modulator therapies, their involvement in the central nervous system, and their age-dependent effects. And lastly, optimization of the FDA adverse event report form, its completion, and then its availability on this public dashboard is warranted to strengthen future data analyses. These are my references. Any questions?
Can you hear me? How about now? Okay. We've had quite a few questions come in on the app.
Okay.
So the first one, we're only 10 months into the year, but they were curious to know if there have been any shifts in mental health data since the changes given to affordability of CFTR medications.
That's interesting. So yeah, we were able to collect all the reports as of the end of last year, but I think that would be a great idea to now, as far as this year's data, collect the reports that are being submitted actively and seeing if there's shifts as far as these adverse event symptoms that are being reported now that there is better access.
You can also come up to the mic if you have a phone or if you have a question too.
I'm not.
The second question is, was it possible to determine if patients with reported mental health adverse effects to ETI had mental health comorbidities at baseline?
So that is a confounding variable that we did try to account for. Unfortunately, within the report itself, it was difficult to determine if anyone had an established diagnosis of, say, anxiety or depression. But that is why we excluded reports that had other suspected ingredients, such as antidepressants or antipsychotics, or any indication that someone was on a medication for a mood-related disorder. Which I want to add, that did limit as far as the power, because as you saw, it cut down the number of reports drastically as far as what we analyzed. But I think that was to address that question. That is a way we tried to limit the effects of that confounding variable.
Could you please elaborate on the reasons of death and details of disabilities?
Sure, yeah. 1 second. Is it okay if I go back to that slide? Okay. So as far as the definition of categorizing death, this is the definition by the FDA that you kind of read through before you check that box. So this, for death, you check only if you suspect that the death was an outcome of the adverse event. And they are actually prompted to not check this box if the patient died using a medication product, but there was no suspected association between the death and the use of that product. And then for life, was it life-threatening or disability?
Disability.
Disability, okay. And for disability or permanent damage, the clear definition was if the adverse event resulted in a substantial disruption in a person's ability to conduct normal life functions. Such a case would it would result in a significant or persistent or permanent change, impairment, damage, or disruption in a patient's body function, physical activities, or quality of life.
Do you talk to Vertex to see if they had any data about mental health side effects?
So the interesting thing is the report does disclose who submitted the report, and a lot of these reports were submitted by Vertex.
Were there any objective data included in the FDA, like PHQ-9 scores or GAD scores, any other like objective measure of worsening mental health?
Unfortunately, within the report themselves, no. Though it is, as far as us as researchers looking at this data, I think it does prompt us to be a little bit more vigilant as far as these mental health symptoms. It's apparent that we already do baseline screenings through a PHQ-9 or a GAD-7 in our adolescent and our adult population. But as far as those younger patients with CF, I think there's been a push to kind of consider what screening tools can we use in that population to properly assess for mental health symptoms, which I know our CF Center is trying to see what is a good either, for example, like the pediatric symptom checklist or the SCARED tool to further assess for any kind of mental health disturbances in that younger population.
Is the data granular enough to see what dose patients were on, if dose adjustments were made in response to the mental health concerns? Are the reports updated?
Yeah, so that was one thing that when I kind of went through the form itself, both the one that's available from the for a consumer to submit to the FDA versus healthcare professional, like I mentioned, there is a area like a part of the form where you can provide that information, both like the dose and if you reduced it and if the adverse effect went away after you did that. Unfortunately, on the dashboard, that information is not readily available. It's not a part of that Excel spreadsheet that you can generate and then analyze. But I do believe that is important to make available, because I think it can strengthen your data and see if there is a change if you make a change to the medication.
And can you please elaborate on or clarify how the FDA dashboard that was used differs from the MedWatch reporting system?
So the forms that you can obtain from the MedWatch reporting system is the information that's available on the dashboard. Like I mentioned, there's certain information that's missing from those MedWatch forms, but most of that information is available and kind of categorized within an Excel spreadsheet on the dashboard.
Great. Well, thank you very much.
Thank you, guys. I appreciate it.
All right. So it's my pleasure to introduce Dr. Cameron McKenzie. She is a clinical pharmacist practitioner at the University of North Carolina in Chapel Hill at the Children's Hospital and Pediatric CF Center. She graduated with her doctorate degree from UNC and completed her PGY1 and PGY2 residency at the Medical University of South Carolina. Her research interests are focused primarily on medication-related toxicities and improvements in monitoring pharmacogenetics and pharmacist involvement in collaborative research. Dr. McKenzie also serves as the residency program director for the PGY2 Pediatric Pharmacy Residency Program at UNC. And I will turn it over to Dr. McKenzie.
Thank you both for having me today. Sorry. Today I'll be sharing results from our pilot study examining the impact of pharmacogenomic variation, specifically on ETI concentrations in people with CF. The study was funded by a grant from Friends Fighting Cystic Fibrosis, and disclosures are there relevant to this. So as we all know, expansion of ETI approval in the US has provided substantial clinical benefits for many of our patients. However, significant variability exists both in the degree of clinical response seen, but also in the type and degree of adverse effects and toxicities that people are experiencing, similar to mentioned previously. Some of the side effects being seen are manageable, but we are increasingly seeing side effects that necessitate consideration for either changing ETI therapy or stopping altogether. In an effort to try and maintain clinical efficacy, but also mitigate these toxicities, clinicians are increasingly opting to make dose adjustments to ETI therapy. And while we know that significant interpatient variability exists for many medications, the body of literature examining the role of pharmacogenomics is growing, making this a potential opportunity to better understand this variation. Given what we know about ETI's metabolism, our group set out to examine whether ETI exposure was correlated with variability in pharmacogenomic phenotypes. Inclusion criteria, we included patients 6 years and older, since at the time we started the study, it was not available to patients younger than that, and who were prescribed ETI and due for clinically indicated labs. We felt like this was important since with a pilot study, we didn't want to add an additional blood draw for patients who have already had to go through so many. We excluded patients who had discontinued ETI at any point or if they weren't due for labs at that particular visit. Blood samples were obtained and plasma ETI concentrations were determined via mass spec. And then buccal swabs were also collected and sent for pharmacogenomic profiles with a commercially available panel. This panel included a number of relevant enzymes, including CYP3A4 and 5, and ABCB1, or P-glycoprotein, easier to say, of which ETI is a substrate of both. Importantly, we also did not ask families to retime their appointment for this lab draw. So in a few cases, we were unable to obtain true trough concentrations. So for that small subset of patients, adjustments were made based on the Cmax to Cmin ratio that's been demonstrated in prior studies. Our baseline demographics are here. Our initial enrollment goal was 50 patients, but we ran into a few delays when the company that we initially contracted with for pharmacogenomic profiling changed their process, so not all samples were able to be processed in time for analysis. Of the 42 patients with complete results, the average age was around 13 years old. This was all done enrolling at the pediatric center only, so for some context. And the majority of patients were female. A little over half were F508 homozygous, and then another 40% were heterozygous with one copy of F508. We did not exclude patients in this pilot study who were on modified dosing regimens, so we did end up enrolling 11 patients who were on a modified dosing strategy in addition to the rest who were on sort of normal, full FDA-approved dosing. So this graphic depicts the distribution of phenotypes that were found for a number of CYP enzymes. The two in the box, CYP3A4 and 5, were our initial genes of interest related to ETI metabolism. You can see for CYP3A4, the vast majority of patients exhibited the normal phenotype, while a small number were found to be intermediate, meaning they have less metabolism of substrates. CYP3A5 is a unique enzyme in that the poor phenotype that's shown in the blue that predominates is actually most common, with many populations lacking a functional CYP3A5. So the few patients shown in red that exhibit the intermediate phenotype actually have higher metabolism than is normal. We also included here phenotypes of 2B6, 2C9 and 19, 2D6 for codeine, and 4F2. After that, we performed a multivariate analysis to determine what factors were associated with differences in ETI concentrations. Sorry. Not surprisingly, dosing was significantly associated with ETI concentrations for all three components. On the x-axis, you'll see each component of ETI separated, then further delineated for normal, which is the NL, or modified, which is the mod dosing. So as would be expected, patients on modified dosing had significantly lower plasma concentrations. These concentrations were similar to those seen in approval studies for ETI, and despite the difference noted between patients with normal and modified dosing, even patients on modified dosing regimens did have concentrations that would be expected to be associated with a therapeutic response based on our available PK data. CYP3A4 phenotype did also appear to be significantly associated with differences, but only in elexacaftor concentrations. On the x-axis, again, each component of ETI is broken out, with this time normal NL indicating normal metabolism phenotype, and the INT or INT indicating that intermediate phenotype, which would have lower metabolism of ETI. This makes sense that for patients who have less CYP3A4 function, they would not be able to metabolize elexacaftor as effectively, and with similar dosing regimens would have higher concentrations at steady state. Of note, CYP3A5 phenotype did not have a significant association. Interestingly for us, ABCB1 or P-glycoprotein phenotype was also found to be significantly associated with differences. Again, on your x-axis, you've got the three different components of ETI broken out. NL, again, represents normal, and this time the VAR represents the presence of a variant that affects ABCB1 efflux, transporter, function, and or expression. ETI is also metabolized, or components of ETI are metabolized by ABCB1, so with variations in that phenotype, here we see higher concentrations of ETI. If you're like me, you're probably also wondering how patients on those modified dosing regimens were doing, since we discussed earlier that dosing regimen did appear to impact ETI concentration. Although not our primary aim, we did collect pre and post ETI percent predicted FEV1 for patients in this study. There were no significant differences between the groups in those on modified or normal dosing regimens, and change in FEV1 after initiation of ETI therapy was also not statistically significantly different. There are some limitations that we should acknowledge to this study. It was obviously a small single center pilot study, and we were limited in timing, so did occasionally have to utilize non-trough concentrations. Given the interesting results of the study, we are pursuing additional funding to help us expand the study to a larger cohort, including patients at our adult center, and then children who were recently initiated on ETI in the 2 to 5 year age group, since they will be having more routine blood draws in their first year of therapy. We were fortunate with the pharmacogenomic panel to obtain a wide array of pharmacogenomic information, and we know from some recent publications that people with CF are on other medications pretty commonly that are potentially impacted by these variations. I direct you to poster 549 by Dr. Esther that looks at the relationship between VCORC1 and CYP4F2 with vitamin K activity, and our adult fellow Alex Despotis also gave a really nice presentation earlier today on the potential role of pharmacogenomics with mental health treatment selection. But I think in the years to come, we will continue to learn about how pharmacogenomics can be utilized to optimize dosing of many medications, maybe including ETI for people with CF. So in conclusion, our study demonstrated a correlation between altered CYP3A4 metabolizer phenotypes and ETI concentrations. Dosing, CYP3A4 phenotype, and ABCB1 phenotypes were predictive of plasma concentrations. Additional data and patient numbers are needed with patients on both full and modified dosing regimens to better understand the relationship between pharmacogenomic variation and ETI exposure. A huge thank you to our study team who made this project happen, Carissa Cam, Chuck Esther, and Tara Lee, and then to our CF Care team and our children and families at UNC Children's Hospital. And with that, I can take questions.
What is the cost of a pharmacogenomic panel or test?
Yeah, great question. And, I think access and insurance coverage to these is so variable between payers. So it's a fair question to ask about, what is the out-of-pocket cost, kind of ignoring insurance. So different panels are different, and different manufacturers of those panels vary, but on the whole, they tend to be somewhere between $200 and $400 out of pocket if the patient was going to just pay and not be reimbursed. You could certainly, and we have on the clinical side of things, occasionally tried to get these approved by insurance first. It's hit or miss. And so sometimes patients, we opt to have them pay out of pocket and then try to submit for reimbursement, just not to hold up the process.
Yeah. Can you elaborate a little bit more about the dose modifications? Were they modified for drug interactions or potential adverse effects? What were the primary reasons of those modifications?
Yes to all. So we had some of each. We had a couple of patients who were modified because of potential drug-drug interactions, but most of them were for adverse effects. The majority of them were because of mental health related or behavioral side effects, so along with the presentation before. And then a couple were also dose adjusted for hepatotoxicity and liver disease.
While it was statistically significant, did you find that enzyme activity variations leading to elevated drug levels was clinically significant in the patients you assessed?
Yeah, so I think, it's a good question, because I think kind of the next step as we think about enrolling more patients is, okay, so we know there's this correlation, but then what do those concentrations mean in terms of both efficacy and toxicity? And so at this point, we have a few examples each way. So, what comes to mind immediately is we have a patient who was on full dosing, was modified because of behavioral side effects, then subsequently enrolled in the study and was found to have that abnormal CYP phenotype of her metabolism. So there are scenarios where it fits nicely like that, and there are others where it doesn't go quite as well together. I think also the role of the ABCB1 or the P-glycoprotein and how that interplays with the CYP3A4 will be interesting to see with a larger patient number. I think with the small group of people on modified dosing, it's just hard to say what's driving that potential different dose relationship, dose response.
Will you be able to assess whether pharmacogenomic variations in those effects on other medications can influence their metabolism of UTI?
Such a good question. I would like to think the answer is yes. I think yes, as we look further into, enrolling additional patients, trying to suss out what is driving the differences in concentration, the differences in responses. I am hopeful that with more numbers and more power to this, that we will have a better sense of, for patients who are on potentially other medications that are impacted by pharmacogenomic variation, does that somehow interplay with the ETI metabolism? Because it's a fair question. And we know there's now a couple of papers, right, that have said that somewhere between 80 and 90% of our CF patients are on medications that could have actionable pharmacogenomic items. So it's a very fair question, and I think there's a lot for us to learn about pharmacogenomics for our people with CF as a whole.
If a patient was found to be a high metabolizer of ETI and they were a non-responder, would you recommend dose increase? Any idea how this would be paid for?
Okay, I'm going to get out my magic wand. No, I mean, it is a fair question, right? Because I think here what we were looking at more was thinking about toxicities that people are seeing. Is it because they're not metabolizing drug and we're having higher concentrations, maybe build up? But the reverse being true would be really interesting. I think, yeah, it would be a fair question to ask if a patient isn't responding and you have proof that they're metabolizing this more efficiently and potentially not seeing the benefit. I do think it would be a fair thing to ask. Now, would insurance allow that? I don't know. I think this is one of those cases where, we would probably try to get to a peer-to-peer conversation and talk with a clinician and present that kind of information that, yes, this is an expensive question to ask, but even if you could make the case for, a 6-month or 12-month trial of that, and then if you didn't see a difference, maybe, that kind of proves your point. But I do think it would be a question worth asking because we have a fair number of patients who aren't responding in the same way that we would anticipate to ETI at normal dosing.
How would a modified dose be covered by Vertex GPS?
Yeah. So I guess the question now, modified in which way? So we do know from some of our learning that when we think about modified doses and decreasing the dosing frequency, we have learned, unfortunately, through trial and error that Vertex GPS financial assistance is tablet-based. So if your patient is using one of the limited distribution specialty pharmacies that has different packaging that allows them to dispense less than the full 84 tablets at a time, patients will actually get proportionately less copay assistance applied to that particular fill based on the ratio of tablets. So that is my PSA to everyone. Now, I don't know what they would say about a higher supply, and I have never run into that situation. I'd be curious if others have, but it would generate even more, I'm sure, fiery conversations.
Have you seen insurance cover modified doses for other medications that are affected by pharmacogenomics? Fluoxetine, escitalopram, statins, etc.
Yes, variably. So, I mean, I think it's a fair question. And unfortunately, in the current landscape where I think it's easier when we think about medications that have existing CPIC guidelines and there's more clear peer-reviewed evidence to support based on this phenotype, genotype, this is what we should be doing with the dose. I think when we start talking about something more investigational like this, that is a much harder sell. But I certainly have seen success with some of those more established drug gene pairs. So maybe we'll get there with ETI.
Yes. Well, thank you very much.
Okay, next up we have Carol Lee. Carol Lee's PharmD. Cystic is a CF and research pharmacist at Valley Children's Healthcare in Madera, California. She holds a Bachelor of Science in Biology and a Bachelor of Arts in English from the University of California, Los Angeles. She received her Doctor of Pharmacy degree from the University of California, San Francisco. In her free time, she enjoys yoga, scenic drives, and spending time with her cat.
Hi, everyone. Thank you for the introduction. So I'm Carol, and today I'll be presenting our project entitled Evaluation of a Pharmacy Technician-Based Preclinic Call Program and its Impact on Medication Adherence in Cystic Fibrosis Patients. I'd like to shout out real quick my other co-investigators on this study, Danielle Herman, our other CF clinic pharmacist, my friend and mentor, she's here today, and also Esmeralda Vasquez, our fantastic pharmacy technician. So in the study, when I refer to pharmacy technician, I'm talking about her. She did a fantastic job on the study. I have no conflicts of interest to disclose. So as we all know, CF patients frequently encounter a high medication burden, taking an average of 10 medications per day. And studies among CF patients indicate poor adherence with chronic medications. Some common barriers to adherence include inability to obtain the medication, high copays, social determinants, and low health literacy, just to name a few. Previous studies have also demonstrated that the integration of various pharmacy services correlates with improved compliance, increased patient satisfaction, reduction in readmissions, and fewer visits to the emergency room. Our previous study looked at how post-clinic follow-up calls performed by a pharmacy technician impacted medication adherence. And this study was previously presented at NACFC 2021. Our technician collected medication compliance data for patients on hypertonic saline 7% and or Dornase alpha using the mean possession ratio, which I'll refer to as MPR. And as you can see in the figure here, we observed that the hypertonic saline MPR statistically improved post-implementation of the pharmacy technician follow-up calls in 2020 compared to no calls in 2019. The Dornase alpha MPR also improved, but this was not statistically significant. So a little more background on our previous study. Our technician made the post-clinic follow-up calls approximately 4 or 5 days after the patient clinic visit. She asked a standardized list of questions to check in on newly prescribed antibiotics and changes to any of the other home meds in order to address any potential barriers. The table on the left summarizes the prescription outcomes. So of the 155 encounters evaluated in our previous study, we saw that 73.3% of patients who were prescribed a new medication at their recent clinic visit were unable to obtain the new medication. And that was usually due to billing issues, questions about the regimen, or other reasons. And of the patients who were newly prescribed antibiotics, only 51.4% had obtained their antibiotic by the time of the post-clinic follow-up call. With these post-clinic follow-up calls, we were also able to identify barriers patients experienced while trying to obtain any of their medications and assess mitigation strategies utilized by the pharmacy technician. These strategies included resolving insurance issues, copay help, question routing to the specific team member, and providing medication clarification. And these results are reflected in the ring diagram on the right. Our results in our previous study highlight the benefit of having post-clinic follow-up calls performed by a pharmacy technician. And so we wanted to study how pre-clinic calls would impact compliance, which brings me to our study objectives for this study. So the primary objective of this study was to determine if pre-clinic follow-up calls from a pharmacy technician improved patient adherence to their mucolytic medications in comparison to post-clinic follow-up calls. And the secondary objective was to identify barriers that patients experienced obtaining any of their medications and to assess the mitigation strategies utilized. This was a single center study of CF patients managed at the Valley Children's Healthcare Cystic Fibrosis Clinic. And to determine each patient's medication fill history, our pharmacy technician made pre-clinic calls to the patient's pharmacies. She also used EPIC adherence reports. The results were then summarized in a table and made available for the team to view via a telephone encounter note in EPIC. Then, before the patient's clinic visit, the team would review the adherence information, and during the visit, they could address any barriers or inconsistencies in the fill history. The table on the left is the medication fill history template that our pharmacy technician filled out a few days before each clinic visit. And as you can see, dispense data was collected for Dornase alpha, hypertonic saline, any modulators, and inhaled antibiotics. Our study only compared compliance data for hypertonic saline and Dornase alpha because that's what was done with the post calls, and we wanted to compare the two data sets. But we also collected dispense data for other important medications like modulators and inhaled antibiotics, because that way we were able to address barriers with these key meds as well. The table on the right is an example of what the telephone encounter note looks like in EPIC for review by the team. Having all the dispense dates laid out in an easy-to-read table allowed our team members to quickly assess adherence right before each clinic visit. So patients served as their own controls and were assessed in 2 phases. The first was in 2020 when we implemented the post-clinic calls and data from our previous study was used. The second phase was in 2021 when we implemented the pre-clinic calls. Compliance data using MPR was collected for patients on hypertonic saline and or Dornase alpha. Then we compared the phase 2 data to the phase 1 data. This is the MPR equation for your reference, and the MPR is a number from 0 to 1, and low adherence is generally defined by MPR less than 0.5, moderate adherence 0.5 to 0.8, and high adherence is greater than 0.8. So for example, if a patient fills their 30-day supply prescription for 8 months out of the year, their MPR for that medication is 240 days divided by the 365 days in a year, which comes out to be 0.66, which is moderately adherent. So moving along to results, a total of 81 patients were included in the analysis for hypertonic saline, which is the top bar, and a total of 70 patients for Dornase alpha, which is the bottom bar. So for hypertonic saline, the mean MPR in 2020 with the post-calls was 0.61 and 0.54 for pre-calls in 2021. This difference was not statistically significant. When looking at Dornase alpha, the mean MPR in 2020 was 0.68 compared to 0.59 in 2021, and this was also not statistically significant. When stratifying the results by age group, mean MPR did look to be slightly decreased in 2021 with the pre-calls compared to the post-calls in 2020 for almost all age groups. The left bar graph shows the results stratified by age for hypertonic saline, and the right graph is Dornase alpha. And in fact, if I can direct your attention to the right graph, for patients ages 0 to 7 in the Dornase alpha group, the decrease in MPR from 2020 to 2021 was statistically significant, with a mean MPR of 0.75 in 2020 to 0.58 in 2021, p-value of 0.02. This graph also shows the mean MPR comparison when looking at male or female sex. The mean MPR also looked to be somewhat decreased when stratifying the results this way, but this was not statistically significant. For our secondary objectives, we wanted to identify some common barriers to obtaining medications in our patient population. And those common barriers we observed include cost, specifically high copays with private insurance. And of course, insurance issues such as changes in the contracted pharmacy. So for example, one of our patients hadn't picked up their medications for several months. And when asked about any barriers to adherence, they stated that the copays were too high. So upon further investigation, we found that the patient had insurance coverage under TRICARE, which is the insurance program for uniformed service members and their families. And once we knew that, we were able to switch the prescriptions over to the plan's contracted pharmacy, and we significantly reduced the patient's copays that way. In other instances, the copay amount was still high, even with the insurances applied correctly. So in several of those cases, our pharmacy technician was able to provide a copay card to the patient or direct them to other avenues of prescription cost assistance. Another common insurance issue was the incorrect application of insurances. Many of our patients have multiple insurances, each of which mandates a specific specialty pharmacy. So navigating that landscape of applying the correct primary and secondary insurances at the correct specialty pharmacy for the specific medication can be incredibly confusing and complicated, as I'm sure you all know. But in these situations, our pharmacy technician looked into the intricacies of the insurance plan requirements and worked with the pharmacies to overcome these insurance issues in order to provide the best medication access for the patient. We also noticed that many patient families were overwhelmed by high medication burden, which oftentimes led to fatigue and not picking up calls from the outpatient pharmacies. Some families also did not understand the need for all the medications and selectively chose the ones that they thought were more important to fill. For these families, team members provided education on why each medication was important and how they worked in the body to treat the patient. In 2021, we also experienced a hypertonic saline shortage, which directly affected medication access for many of our patients, and unfortunately, we had no control over this barrier. In some cases, we were able to switch patients to a lower strength or a different package size, but that was just based on what the pharmacy had available. So based on our results in this study, it may seem that post-clinic calls were better, but the MPR results were still similar. And none of the data was statistically significant, barring the change in mean MPR for Dornase alpha in the patient's ages 0 to 7 group. In comparing the pre-clinic and post-clinic calls, we did see benefits and limitations to both. With the pre-calls, we were able to review the patient's adherence data prior to the visit and address any barriers and medication issues at the clinic visit. However, simply filling medication on time every month does not necessarily always equate to patient adherence. The pre-clinicals themselves also offered no interaction with the patient between visits. since we were calling the pharmacies. We also encountered some difficult to address barriers. Some patients continued to insist that they were compliant despite us pointing out their low fill history. With the post-clinic calls, the best benefit was that they provided us with the opportunity to address a variety of medication and even non-medication issues outside of our quarterly clinic visit cadence, because in those cases, we had direct contact with the patient or patient's family during these calls. And the NPR data from 2019 to 2020 in our previous study did show that the post-clinic calls impacted adherence. It was statistically significant for hypertonic saline. But keep in mind that the post-call data was compared to a time with no technician intervention. And this current study compared 2 different technician interventions, the pre and the post calls. So it really would be hard to directly compare the results of our 2 studies. Perhaps a better study design would have been to compare the pre-clinic call data to no intervention as well, and then compare those results to the previous study results. So there were also multiple factors that could have led to the somewhat perceived but not statistically significant decrease in mean NPR from 2020 to 2021. These factors include the rollout of ETI to many of our patients in 2020, and several of our patients were doing so well on modulators that their adherence to the rest of their medication regimen began to drop. COVID-19 pandemic also didn't help things. They led to an increase in telehealth visits and less in-clinic interaction with the full interprofessional team, and this could have impacted adherence as well. The hypertonic saline shortage in 2021 may have also directly impacted adherence data for that year. So overall, we do see the benefit of both call strategies. And now that we've studied the impact of both, I expect we will implement a hybrid kind of best of both worlds approach, where our pharmacy technician can conduct post-clinic calls just for patients with new prescriptions, such as modulators and antibiotics. And then she could do pre-clinic calls just for patients with known adherence issues. And that way we can apply a more targeted strategy to optimize adherence based on individual patient needs. So while there are many factors that can affect medication adherence, our results highlight the benefit of calls performed by a pharmacy technician. Not only do they have the specialized knowledge and familiarity with navigating insurance requirements, but they are able to interact with patients and their families to successfully identify barriers to non-adherence and then employ the appropriate mitigation strategies. So for our clinic, the pharmacy technician was the best team member to implement these calls. In conclusion, it's difficult to definitively conclude that post-clinic follow-up calls are better, since we did find similar NPR rates and no statistically significant difference when comparing the efficacy of post-clinic calls to pre-clinic calls. However, post-clinic calls allowed us to resolve more issues with obtaining new medications more quickly. We also found that patients were more open to working through insurance barriers when they were addressed right away within a few days of the clinic visit. So ideally, we would implement a hybrid of both call strategies, but if resources are limited and I had to recommend one over the other, post-clinic calls did prove slightly more impactful on adherence. Thank you for your attention. Here are my references, and I will now take any questions you may have.
All right. So one of the questions that has popped up several times is, did you compare patients who were on highly effective modulators versus those who weren't? And kind of looking at the results of the Simplify study and discontinuing hypertonic and Dornase alpha.
That is a very excellent point, and I would love to do it as the next part of our study there. It certainly would be easy to go back and add that stratification in order to look at the results that way. I don't believe we have applied the effects of the Simplify trial for that many of our patients, but that is a great thought.
Is the pharmacist technician team associated with the hospital pharmacy dispensing CF medications? If not, who's funding these positions?
Well, none of our clinic members who you see on the screen here our full-time FTEs in our clinic. We also work at the main Valley Children's Hospital where we staff clinically. Our technician works in other clinics as well. So funding at first, we did get some from the CF Foundation grant, but currently we're being funded through the pharmacy department.
Do you have a system built yet to notify the technician when a new prescription is sent, or is this a manual process?
It currently is a manual process. So if there's any thoughts on how to get that automated, I would love to hear more. Our technician, she's amazing. She'll actually go through and manually look at that. She is present on all CF clinic days, which is, the main CF clinic day, which is Thursday. And so she kind of is in the know as to when new prescriptions are sent.
When looking at hypertonic saline compliance, did you only look at patients with scheduled doses only? How did you handle it with PRN dosing?
That's a great question. We only looked at scheduled dosing because then we were able to assess the full kind of MPR for the year because we did look at annual MPR data. We didn't look at any PRN usage of hypertonic saline, but it is a good thought.
Another interesting question that's come up several times is how did you handle patients during acute admissions and their MPR, and how did that affect their utilization?
That's definitely true. As we all know, when patients get admitted, they get a stockpile, and the MPR data was definitely affected. I will say we did not exclude those patients, but we didn't exclude them from either group, so it's just kind of part of the data. For the admissions, yeah, we didn't exclude them, but it is a good thought.
Given that some patients report being overwhelmed by calls, did you consider alternative methods of communication, such as MyChart?
So we are trying to kind of optimize our MyChart use. We're looking into maybe sending patients satisfaction surveys that way, patient reminders. We currently do via MyChart currently. As for follow-up regarding medications specifically, I think it's a great idea. We kind of just need to learn how to optimize our MyChart usage and work with our organization as to how to implement that process. But currently we are just doing manual calls. They are generally pretty good about picking up calls from our clinic. I don't know about the pharmacies though.
What do you estimate your response rate as?
I mean, our technician, if she didn't get a response the first time, she would call again. And so I wouldn't say the response rate was 100%, but I do think it was fairly good.
Another question is how did you address evident non-adherence that was identified? So the people who had very low MPRs, and then do you also let patients and families know about the risks of insurances denying coverage if they're not filling medications consistently?
Yes, that's kind of our scare tactic. We also kind of just try to hit them from all avenues. The pharmacist would go in, the pulmonologist will go in, the nurse will go, and we'll be like, hey, you're not filling your meds. And I think eventually they, maybe it gets through to them. And we do have a couple of instances where we kind of just try to drive that point home and really try to educate them on why it's important, what is the mechanism of these medications, because I feel that once a patient really understands why they're on a medication, it just becomes more important to them for their own health if they know tangibly what it means for them. And so in many of those cases, the patients did start to fill the medications again. Now, whether they were adherent or not, that part is up in the air, but at least they were filling it. Didn't happen with all the patients, but some, they did respond.
Is the technician also consulted prior to sending the scripts to avoid or remove obstacles ahead of time?
Yes. So for any modulator therapy, we definitely loop in our pharmacy technician because she can always get the paperwork started, already know what insurance coverage the patient has, already tell us what specialty pharmacy we should send it to avoid the headache of rerouting prescriptions and all of that jazz. So we definitely loop her in. She helps us every step of the way. And that's really kind of streamlined the process, at least for prescription of modulator therapies.
And what kind of feedback did you guys get from your patients and families, or like your patient and family advisory committee, on these types of calls?
I think really with the post calls, we got very favorable feedback, just because, sometimes patients will be prescribed some Toby or another inhaled antibiotic. It won't be covered, but they won't reach out to us. So preemptively calling them and getting those resolved right away, we did get very good feedback on that end. As far as the patient advisory committee, not sure what they said, but we did get the green light to do the pre-call study, so.
Are there any EMR scoring tools you would use to help identify target patients with adherence issues to know who to make phone calls or post-call tos, or are these patients identified manually?
So for the most part, it's a mix of manual and us knowing the patient's stories and how they're doing, but we also try to look at objective data such as FEV1 and really how their lungs sound, just because if their NPR is 1 and they're filling everything on time all the time, but their FEV1 is dropping, or if their lungs sound terrible, then obviously something is not adding up. And so we definitely kind of do a combined approach, but I think to streamline that and specifically look at objective data for each patient would be a good idea if we could get that automated somehow.
Great. Well, thank you very much.
Thank you.
Okay, next up we have Maddie Hill. She's a pharmacist at Intermountain Primary Children's Cystic Fibrosis Center, training at Primary Children's Hospital. After residency, she worked at St. Luke's Cystic Fibrosis Center of Idaho for 2 years before transitioning to her current position.
Okay, yes, thanks. So I'm Maddie. Like you said, I previously was at the St. Luke's Cystic Fibrosis Clinic in Boise, Idaho. My current position now is at Primary Children's in Salt Lake City, Utah. But this presentation and this poster project took place at the St. Luke's Clinic in Boise. So I'm going to share with you today the outcomes of our pharmacist and pharmacy technician-led MRSA eradication program. I'm showing you this specific example, but really what I want you to keep in mind throughout the presentation is how you can extrapolate this and see how you can apply this model to other areas as well. And I just wanted to point out the other members of our team who were involved with this. Our other pharmacist, Sabrina Sherwood, our pharmacy technician, Kathleen Odell, our nurses, Jamie Hill and Tiffany Rickow, and Dr. Perry Brown. And we have no disclosures for this presentation as well. So a little bit of background information. Methicillin-resistant Staphylococcus aureus, or MRSA, is a pathogen that we see in the lungs of our CF patients and has been associated with decline in lung function. One thing that we can try to do for these patients is try to eradicate the MRSA in hopes of it not becoming colonized and preventing further lung damage. As we know with our CF patients, once we have a bacteria growing, it can be challenging to get rid of it. Because of this, the therapy for an eradication attempt includes multiple antibiotics, some topical agents, and environmental cleaning interventions as well. So all of this requires careful consideration in terms of drug interactions, monitoring, and tolerability with these medications. A lot of them can have some side effects, so that's something to consider as well. To give this therapy the best shot at success, it's very important that patients complete the therapy as prescribed. We recognize that this is a lot for our patients to take on and a lot for our clinic to coordinate as well, between deciding which antibiotics are appropriate in terms of drug interactions and allergies, counseling, and appropriate follow-up. So at St. Luke's, our center data showed that 40% of patients with MRSA failed to complete this extensive eradication regimen as prescribed. We as the pharmacy team identified this as an area where we could potentially make a difference. I know a lot of you out here are pharmacists or pharmacy technicians, and I know how much you love your protocols. And so we definitely took advantage of this opportunity to create a protocol, nice standardized protocol, and really prompted us to look at this as a quality improvement project. So, like I said, we understand that this is a huge burden on families to take this on. The main question that we posed with this is, can our pharmacy team help to break down barriers that patients face with these complex regimens? How can we help them successfully complete this therapy? So our primary objective was to determine the percentage of patients who successfully complete the MRSA eradication therapy before and after implementation of this pharmacy-led program. We defined successful completion as achieving greater than 80% to each medication in the antibiotic regimen. We also looked at the percentage of patients with one MRSA negative culture 3 months post-therapy. We included patients who had a positive MRSA sputum culture with no history of MRSA within the prior 12-month period. So excluding patients who grew MRSA at another point in the prior 12 months or who received MRSA eradication within that period. So if a patient grew MRSA within the past 12 months and now had another positive culture, our clinic then considered them as colonized. So this is figure 1, and this is the main part that I want to emphasize as far as trying to extrapolate this and thinking about using this for other areas where pharmacy could potentially help in the same way. So the first step in this process is prescribing. So this is where the pharmacist comes in, really helps make that choice in what therapy is going to be best for the patient based on patient-specific factors, allergies, and making that really tailored to that specific patient. Also completing a drug-drug interaction analysis, individualizing the dosing recommendations made, and using a multimodal way to provide education to the patient. So we verbally stated this either in clinic or over the phone with the patient or family. And we also provided a handout that I'll go through in the next few slides to kind of lay out and provide a visual tool for them. The next step is our rockstar pharmacy technician. She was really focused on the accessibility of the medications. So actually getting the medication in the hand of the patient and the family. She made sure that prior authorizations were completed as soon as possible, same day. Also making sure, as we talked about in the last presentation, that all of the billing problems were sorted out on the pharmacy level. So calling the pharmacy, making sure they're billing the appropriate insurance and in the appropriate way. And also, depending on what the copay was, looking for any sort of copay assistance necessary for that and making sure that cost wasn't a barrier for the patient. And then finally, the pharmacist would follow up, making sure that the patient did pick up the medication from the pharmacy. We would also contact the patient, so either by phone or by the electronic medical record patient portal for secure messaging there. And we would ask them, assess any side effects that they may be having. And if they were having some side effects, if we needed to adjust our regimen based on those. One example was we had a patient who wasn't tolerating a high dose of Bactrim that they were getting. And so we were able to adjust that dose for them, lower that, and they were able to successfully complete the rest of the therapy without having those GI effects that they were previously experiencing. We would also assess for any barriers to taking the medication, so actually getting that medication in as prescribed, and if any changes needed to be made for therapy at that point. And then finally, we would make sure that we had coordinated the repeat sputum culture with the patient and that those orders were placed. Typically, this was timed with their next clinic appointment in about 3 months. So I want to show you the handout that we individualized for each patient. While we review all of this information in clinic or over the phone, it's a lot of information to take in at once, and so it can be helpful to have this visual. Especially for our pediatric patients, a lot of times maybe one caregiver we're speaking with and providing this information to, but they may have multiple caregivers at home. So this could be a really helpful tool for them to look at this in a very organized way and see what's going on with this. For the sake of time, we won't go into detail about the medications, but the first part of this handout that we provides the patient with an organized medication chart with the different components of their regimen. So this includes the name of the medication, administration instructions, duration, and potential side effects to monitor for. At the bottom of this chart, we include the pharmacy that they'll be picking the medication up from, the pharmacy phone number, how to contact the clinic and the pharmacy team specifically, and a note of a reminder of why this is important to follow this as prescribed. So really taking home, the goal of this is to decrease MRSA colonization in the lungs, improve outcomes, and it's important to follow these instructions exactly to increase the chance of eradication. And finally, the last portion of this handout, we provide a little visual to show some counseling points on how to use and measure the mupirocin nasal ointment. We've found that this has been super helpful for families because just eliminates one area of questions that they could potentially have and contact us for as well. And we also include some information on the environmental interventions that we recommend too. Okay, so for our results, we looked back over a 1-year period prior to implementation of the pharmacy-led protocol from August 2019 to August 2020. During that period, we identified 5 patients who underwent MRSA eradication therapy. After implementation of the protocol in August 2020, through November 2022, 7 patients underwent MRSA eradication with the pharmacy-led program. So if you look at the y-axis over here on the left-hand side, you'll see the percent of patients. In the first pair of the bar graph, you'll see this is looking at the successful completion of the MRSA eradication therapy. In the blue, this is the percentage of patients prior to implementation of the pharmacy protocol. And in the orange, this is after implementation of the protocol. So 2 out of 5, or 40% of patients in the pre-implementation group successfully completed therapy. Some reasons we identified for therapy failure included medication access issues, side effects, and educational barriers. In the post-protocol group, all 7, or 100% of patients successfully completed the MRSA eradication therapy. In the second group here, the second pair of bars, this is looking at negative MRSA sputum culture on subsequent culture. So again, in the blue, you'll see pre-protocol results. So this is 4 patients, or 80%, had negative MRSA sputum culture on the subsequent culture there. And in the post-implementation group, 6 patients, or 86%, had a negative culture. And so in conclusion, this really showed, and the main point I want you to take away from this is that a pharmacy team-led MRSA eradication program did increase the rates of successful therapy completion. Biggest takeaway is that pharmacists and pharmacy technicians are equipped to overcome these barriers to successful therapy. So that's, like I said from the beginning, kind of extrapolating this concept to other areas. My challenge here is to anyone who is a part of a pharmacy team, try to identify, see where you can create a standardized process for this to help break down barriers. I know you all already do this in so many different ways, but it can be extremely beneficial to have a standardized process to help us take a more proactive approach rather than being reactive to each of these situations. And then I wanted to give a shout out to the St. Luke's team as well. You all are incredible. And for this project specifically, special thanks to our nurses who really helped us with the data collection and triaging any calls that patients had. And with that, I will take any questions.
Am I on? You can also come up to the mic with any questions or submit it through the app.
I just managed to find the mic here. So thank you for this talk. Sorry, Marianne Willebay. And I want to ask, is with the eradication rate was the same, if they adhere to all the things or not, were you able to determine which of the items were the most difficult?
Yeah, so I think a combination of things for different patients and different families. I think, like I said, some reasons we identified before for barriers to completing the therapy before the implementation, a lot of it was medication access. So sometimes patients didn't even pick up the medication from the pharmacy in the first place, and then we find out about it weeks later. Some of the other ones are just because it is so complex. I know with one patient, they had multiple caregivers in the family, and it was difficult for them to coordinate that between multiple caregivers. And did someone already give this medication today? And so a lot of doses were missed at that point, which they discovered at the end when they had an excess amount of antibiotics left. So I think those are some of the biggest barriers that patients face and where pharmacy can really help with that.
Because, one of the reasons I'm asking, because we have the ongoing second trial on this with an easier regimen. So, okay.
Yes, which I think would be very beneficial and useful for patients. Absolutely. Yeah. Thank you.
Was the duration and number of negative cultures sufficient for your secondary endpoints to ensure successful eradication?
I think with us being a little bit of a smaller center, it was a very small sample size to compare that. So yeah, I think it would be useful to continue to look at this data over time to get some more information there. That's a great point.
How long did eradication persist?
So we used 14 days for the oral antibiotics for that. We used 2 oral antibiotics. So a short, and that was kind of for this specific, for MRSA eradication therapy, it was good to emphasize this is for a short amount of time, 2 weeks, you guys can do this.
And how long did you see negative cultures until the next positive when you considered them colonized?
Yeah, so that's a great question. There were some patients who did have that initial negative culture, and then on the next sputum culture did have a positive culture. And so at that point, we would consider them colonized. Mm-hmm. Yeah, thank you guys.
Okay, it is my pleasure to introduce our last speaker of this morning, Alan Shih. He is a third-year PhD candidate in Dr. Paul Berzinger's lab at USC Mann School of Pharmacy. His research focuses on investigating the epidemiology, mechanisms, and therapeutic approaches for CFTR modulator-mediated drug interaction liver injury. He has also conducted drug-drug interaction studies with CFTR modulators to support the lab's overall goal of optimizing safety and efficacy of CFTR modulators and other CF treatments in clinical practice. Alan completed his undergraduate studies at USC as well, graduating with a Bachelor's of Science in Human Biology with a minor in Science and Management of Biomedical Therapeutics and specializes in applied analytics. So it's my pleasure to welcome Alan.
First off, thank you, Laura and Katie, for the great introduction, and thank you to all the previous speakers as well as the audience for being such a great audience today. So to start off, hi, I'm Alan. I'm a PhD candidate in Dr. Paul Behringer's lab at USC School of Pharmacy, and I am really excited to share with you our research on the evaluation of ETI's drug-drug interaction potential with statins. And I have no disclosures or no relationships to disclose. All right, to start us off, I wanted to introduce you to both ETI and statins and the importance of the drug-drug interactions between them, as well as why that could be an issue. First off, just want to start off in a positive note. So for the good news is that one of the benefits of ETI is that it can be used in lung transplant recipients, since it's actually still indicated for extrapulmonary manifestations of CF. So according to a recent clinical study, ETI has resulted in statistically significant extrapulmonary benefits for blood glucose. You can see a decrease in A1C, and anemia, which resulted in an increase in hemoglobin in CF lung transplant recipients. However, ETI use in lung transplant recipients is complicated by poor tolerability and safety concerns. So you can see there's mood changes, certain GI symptoms, and transaminitis. Unfortunately, this has resulted in discontinuation in about 42% of patients after a median of 56 days. And additionally, this picture is further complicated by the fact that most lung transplant recipients get statin treatments for immunomodulation. You can see I like to start with the good news. So statins are used for immunomodulation post-transplant, and they have been efficacious in reducing risk for primary graft dysfunction and for decreasing acute rejection of the transplant. However, statins do come with their own safety concerns, as well as adverse drug reactions that overlap with ETI, such as GI discomfort. So you can see there's myalgia, rhabdomyolysis, and general myopathy. And with potential drug-drug interactions between ETI and statins, the increased exposure of statins will lead to safety concerns. So what does this drug-drug interaction look like in the body? To begin with, the statin has to be absorbed by the enterocytes, and then it will pass to the liver through the portal vein for first pass metabolism. And you can see that statins are substrates of CYP and OATP. So that's important to keep in mind, because what happens next is that elexacaftor and ivacaftor do inhibit metabolic enzymes and transporters such as PGP and OATP. So essentially what happens is that statins end up being sandwiched by the inhibition effects in the gut and the liver. This increases bioavailability in the enterocyte and decreases clearance, increases bioavailability in the enterocyte and decreases clearance in the hepatocyte, which leads to an increased plasma exposure for statins. And just as a note, when I refer to ETI from now on, primarily means ivacaftor and elexacaftor, since tezacaftor doesn't have direct interactions with statins. So in all, you can see how there's a risk of potential adverse drug reactions, such as the myopathy and myalgia, due to increased exposure of statins from interaction with ETI. But the extent of the magnitude with drug-drug interactions has not been well studied yet. So this is what our research aimed to address, and we hypothesized that this poor tolerability of ETI in lung transplant recipients is due in part to drug-drug interactions that alter the pharmacokinetics of ETI or concomitant immunomodulatory therapies such as statins, and that alternative dosing strategies could mitigate the risk for adverse drug reactions due to ETI. And so we first aimed to determine the in vitro inhibition of CYP by ivacaftor and OATP by elexacaftor. And next, we aimed to determine the effect of ETI on statin pharmacokinetics to guide the selection of optimal statin and dose in lung transplant recipients. So the big picture is that these in vitro inhibition parameters can actually be input into physiologically based pharmacokinetic modeling software that can predict the drug-drug interactions to guide the selection of the optimal statin and dose. All right, so for our first aim, we addressed these drug-drug interactions in vivo. For ivacaftor, CYP3 inhibitions, the assay involved differentiated hepARG cells, which is a liver cell line. And the measurement was intracellular luciferin luminescence, which is a substrate of CYP3A4 after incubation with ivacaftor or control. And for CYP2C9, we utilized liver microsomes, and the measurement was intramicrosomal substrate concentration using mass spec after incubation with ivacaftor control. For elexacaftor, similarly, we used OATP overexpressing HEC293 cells, and we measured the intracellular substrate concentration after incubation with elexacaftor or control. So onto our results. So you can see that there is a dose-dependent relationship for ivacaftor CYP3A4 inhibition, as well as ivacaftor CYP2C9 inhibition. And those dotted lines are from our previous publication on the predicted plasma and liver Cmax values. So the inhibition constant is within the physiological range for ivacaftor. Next up for OATP, elexacaftor is an inhibitor of OATP and is an inhibitor of 1B1 and 1B3. So once again, it is a dose-dependent relationship. You can see it's quite potent with a Ki of that is far beneath the physiological range. So this gives us a picture of the potential effect of ETI on statin exposure. Elexacaftor is quite a large contributor. But if you're a clinician and you're looking at these numbers, well, what does this mean what does this mean to the patient? What does this mean to drug-drug interactions? So that is what our second aim, which involves the PBPK modeling, will address. All right, so once we have these in vitro parameters, we can plug them into modeling software to figure out what it might look like in humans. So if you look at the left here, this is the physiological structure diagram of the structure that is modeled within this PBPK software. And so it incorporates a multi-compartmental organ model that accounts for both organ volumes and blood flow. And we used a perfusion limited model because ETI is lipophilic, has a high volume of distribution, and is not limited by permeability. And on the right, you can see that there are many steps in our PBPK modeling workflow. To begin with, you would input the physiological and physical chemical properties. You can see them over here. And you would use those to predict published PK data. So you predict the published steady state concentrations in plasma. And so that's what we already did for ivacaftor and elexacaftor. And the statin model is already built into the software. Next up, we would input the in vitro interaction parameters. So it'd be ivacaftor and elexacaftor inhibition. And for elexacaftor, we actually used elexacaftor for CYP2C9 because its inhibition constant was actually more potent than that of ivacaftor CYP2C9. This has already been published in the NDA. We would use this to predict known published clinical DDI data. For example, for ivacaftor, we would predict the interaction between ivacaftor and midazolam and its impact on increasing the exposure of midazolam. And finally, we would use it to predict statin ETI drug-drug interactions, which is not currently known. All right, so first we also had to select the statins that we used for our model. You can see in this diagram, there are 3 generations of statins, and our first screen just screened out all of the high CYP metabolized statins. And then we wanted to find the lowest sensitivity for OATP. So this is based on a study of which statin exposure was least impacted by people with impaired OATP1B transporters. That allowed us to narrow down our choices and gave us the hunch that rosuvastatin was going to have the lowest magnitude of interaction. So we compared rosuvastatin, pravastatin, pitavastatin, and also threw in atorvastatin because it's commonly used. And so our modeling incorporated the elexacaftor, ivacaftor, and the inhibition parameters plus the built-in statin model, which ended up generating steady state concentration time curves with or without inhibition. And so any AUC ratio outside of FDA guidance was considered significant. So the AUC ratio is the AUC with inhibition divided by the AUC without inhibition. And you can see in rank order, rosuvastatin is actually the least impacted by ETI drug-drug interactions. And the rest of these ratios can actually be used to determine optimal dosage for other statins with concomitant ETI. And finally, this is our dosing recommendation with ETI. I want to draw your attention to the red line and the green line. So you can see this is the results of the PBPK modeling. With 10 milligram rosuvastatin, this is the regular exposure, but with interaction, the model tells us that it's roughly double of what it used to be. Now, if you compare the 5 milligram with interaction and 10 milligram with interaction, you can see that their AUC at steady state is really close. It's around 85% that of 10 milligrams without interaction. So based on the aforementioned AUC and Cmax ratios, about a 40% reduction in dose for rosuvastatin would be appropriate with interaction with ETI. So in the real world, this looks like a reduction from about 10 milligrams to 5 milligrams every day. And so in conclusion, our PBPK modeling of drug-drug interactions can help inform dosing for statins, and not only in lung transplant recipients, but basically anyone taking ETI and statins, perhaps for cholesterol or hyperlipidemia. And also we found that rosuvastatin is the least affected by drug-drug interactions with ETI. So our model provides a gap, basically a bridge until clinical validation studies are done for for ETI and rosuvastatin. And so for the future, the PBPK model can be expanded to include the effects of elexacaftor and ivacaftor metabolites on OATP1B or CYP3A4 enzymes. In the future, clinical studies can also be conducted to verify these drug-drug interactions of elexacaftor with OATP1B substrates. And rosuvastatin dosing still requires further clinical validation to validate our model, both pharmacokinetics alone and in combination with ETI. And so I'd like to thank my PI, Dr. Paul Berenger, Dr. Anjin Hong, who is a recent graduate of our lab, and my undergraduate student, Cole Cornwell, as well as generous funding from the Cystic Fibrosis Foundation, Anton Yelchin Foundation, and our collaborators as well. And yeah, I'd like to open the floor to any questions. You can check out my poster later today. It's poster 422. Thank you so much.
I have a question. So based on this, would you recommend clinicians starting to dose reduce, or would you anticipate more adverse effects if the statins are not dose reduced in terms of combination with ETI?
Yeah, so I think in general what the modeling does, it provides a starting point to allow for, I guess, reduced guesswork or less trial and error in clinical practice. And so, as you can see, statins already come with these side effects of muscle pains. And so, if you were to use them with ETI, I think it would be safe to reduce to half of what you're originally intending to give them for either immunomodulatory or anti-cholesterol effects.
What recommendation do you have for a dose reduction in atorvastatin as opposed to rosuvastatin?
Yeah, that's a great question. So we can jump back to the slide. The AUC ratios actually give us an answer, the guidelines for how much we should dose reduce. So for rosuvastatin, it was a reduction of about 40%, but atorvastatin had a high AUC increase of basically from one would be equivalent, and it'd be 3.4-fold. So you would reduce about 70% for atorvastatin. This is based on the AUC ratios.
Are there any more questions? Oh,
I have a quick question. I was just wondering if you have plans to share this information with like our drug references. So I know, like you mentioned, the CYP2C9 interaction is listed in the package insert. But for example, if you use LexiComp to try to run this interaction, it doesn't flag. So I was wondering if you're already planning to share that with that vendor.
Sorry, could you repeat the question?
Yeah, so typically like when we run drug interactions on a patient's profile,
Yeah.
if you don't have them memorized, right, you would run them through LexiComp, which is a software vendor that kind of runs all these interactions through. And currently this interaction doesn't flag, even though it is listed in the package insert. So I was wondering if you're planning on sharing your findings with them.
Yeah, I definitely do that. Yeah. And actually, our group also has prior published a review paper on drug-drug interactions involving ETI as well.
Great, thank you.
Any other questions or comments? Our system had a little bit of a delay in questions, so there's a few questions for previous presenters, if they don't mind answering some of those questions that came in a little bit later. So this one is for Maddie. It was a question about what was the timing of the pharmacist follow-up for step 3 of your MRSA protocol?
All right, thank you so much.